So I'm going to, again, move on to the public comments because I do want to make sure we end on time. If there are people in the room who want to make a comment, please go to a mic. And Robbie, I guess you're taking comments for this session. Again, I want to ask you to limit your comments to 2 minutes, and please start by identifying yourself and if you have an organizational affiliation.
Great,
please.
Thank you. Yes, I'm Dr. Sarah Lynn Mark. I'm the former senior policy advisor at the White House Office of Science and Technology Policy and the founder and president of a nonprofit with its genesis there. It's called iGiant, which is an acronym for the impact of gender and sex on innovation and novel technologies. Throughout the day, you've talked about various social determinants, what we also call human factors, such as age. I'd like to see that there also be a discussion on sex and gender. The FDA had a very robust symposium back in October discussing the impact on opioids, I believe also nicotine. And I think that is an extraordinarily important variable. And as we move towards a more personalized precision approach, I think in our guidelines to be efficient and safe, that should be addressed.
Thank you. Roberta White, do we have a comment from the internet on this?
This is from our audience. We need new knowledge about how to manage tolerance and withdrawal among hospitalized patients with serious, perhaps life-threatening comorbid conditions, for example, going into withdrawal during intubation for respiratory failure, those undergoing anesthesia, sedation, or medically induced coma. Need more research to focus on early identification of patients with addictive disorders related to illicit drug use, as well as those with tolerance withdrawal from illicit opioid use before they develop complications related to unplanned withdrawal during hospitalization.
Great, thank you. Any other comments from the room? Again, please introduce yourself.
Hi, Maureen Cooney, again from American Society for Pain Management Nursing. I just want to comment on a couple of things. I know that the charge of this group is really looking at opioid use after hospitalization. But I think, as has been said today, we do need to look upstream before we get to that point a bit. There are different models out there now looking at how we can reduce opioid use in the hospital setting, which would potentially lead to after. I'm seeing more and more of a focus on looking at opioid weaning preoperatively, particularly in the case of elective surgeries. So I think that that evidence needs to be looked at. I don't know that there's anything really solidly out there yet, but there are some programs where they are trying to wean preoperatively so as to reduce the overall amount that's used in the hospital and post-op. Then there's another model that's looking at that perioperative or post-operative acute pain management, where I think it may be beneficial for the group to look at what are we doing in terms of models after hospitalization before sending those patients off to their primary care providers. So those would be two areas that I would urge looking at. Thank you.
Thanks. Roberta, more comments from the remote audience?
Right. I'm going to combine two comments because I think they're very related. An OR-PACU, what was it, post-operative care unit nurse recommends that they get more education on how to deal with opioids. I'm sorry, I apologize here. Are not adequately educated in questioning opioid prescriptions from surgeons or pain MDS, nor how to work as a team in asking valid questions, best practices, and even how to advocate and educate our patients. So the question is, or the comment is, that there's more education needed, and what we need to examine what level that should occur at. And secondly, what do you do about patients who tell you they scored morphine or heroin the day before a day or day of surgery, and how to deal with those if they're abusing opioids?
Okay. If there are no more comments in the room, Roberta, you want to do one more from the internet?
I'm a legal nurse consultant for 18 years and a member of the American Legal Nurse Consultants. I foresee that as more and more patients will seek legal actions if they become addicted from excessive opioid prescriptions from physicians, as well as mismanaged care from surgeons, primary care physicians, or pain physicians. If state attorneys general and regional district attorneys are not able to suit opioid, opioid pharmaceutical manufacturers and distributors, there will be other venues to file lawsuits. I'm not sure this is in our scope, but we have already seen this in medical malpractice, in OBGYN and other areas. I think that's one comment, and do you want one final one?
Why don't you do one more, and then it looks like we're getting a little ahead of schedule, which is always good to invest in the future.
We had a very short break. There are so many guidelines in development. They recommend that we work with organizations such as CDC and the Pain Management HHS Task Force and the American Academy of Physicians to come up with consensus guidelines.
Okay, well, thank you all very much. We're 5 minutes early because of the relative low number of comments. We'll add it back to the next panel, Roger, and we can take some more committee questions, I think. So let's take a break, and let's come back at 5 of 3. Thank you.